Assalamu alaikum. Today we will read AKP clinical case number 6, that is a 4-year-old who requires palliative care analgesia. As we know that palliative care analgesia is required by patients who are dealing with serious illnesses and experiencing pain that needs special attention. It focuses on comfort rather than curing the illness. The goal is to make sure the person feels better and can enjoy the best possible quality of life. So it is important to understand who needs palliative care analgesia. Palliative care analgesia is required by patients who are experiencing pain due to some life limiting conditions like cancers. Advanced cancer can cause severe pain. For example, a tumor pushes on a nerve or bone, it can hurt a lot. Treatment like chemotherapy or surgery can also cause pain. Children with illnesses like neuroblastoma or leukemia often experiencing pain. Other patients with chronic disease like heart failure or lung disease can also cause pain that does not go away. They need palliative care and analgesia. The main goal is to relieving from pain and improve quality of life. So how it works? The care is given step by step depending on how bad the pain is. If the pain is mild, medication like paracetamol or ibuprofen are used. If the pain is moderate to severe, stronger medications like morphine, oxycodone or fentanyl are used. For specific conditions like nerve pain, drugs used steroids or gabapentin. Other methods like physiotherapy, relaxation, exercise, or counseling may be used for relieving of pain. Pain is a subjective experience, and that's the reason why it cannot be objectively measured. Hence, this is important to remember pain can only be assessed. There are many ways institutions evaluate and categorize pain. The most quantitative way is by using a scale. Some of the scale options include the flag and von Becker pain assessment. So there is flag pain scale. It designed to assess pain in children aged 2 months to 7 years. It focuses on 5 behavioral categories: face, leg, activity, cry, and consolability. Each category is scored from 0 to 2, reflecting the child's pain level. Observation include facial expressions, body movement, and the child's response to comfort efforts. Second is Von Becker Faces Pain Scale. It recommended for children aged 4 years and older who can self-report. It uses a visual scale with faces ranging from a smiling face means no pain to a crying face means severe pain. It helps children point to the face that represent their pain level. Next is pain management ladder. It is a structured approach to treating pain where medications are adjusted based on the severity of the pain. The aim is to ensure that pain is adequately controlled while avoiding overtreatment or unnecessary side effects. Here is how it works step by step. Step 0 is no pain. Step 1 is mild pain. It scores 1 to 3. Medication here used start with paracetamol. This is effective for mild pain and has minimal side effect when used at appropriate doses. Ensure regular doses are administered to maintain a consistent effect, especially during the first 3 days. Step 2, for mild to moderate pain, it scores 4 to 5. Medication here is aiding with paracetamol NSAIDs, like ibuprofen, if not contraindicated. NSAIDs reduces inflammation, which is often a source of pain, and making them particularly effective for bone pain or inflammatory conditions. Monitoring for side effects like stomach irritation in children with other medical conditions. Step 3, moderate. It scores 6 to 7. Here continue with regular paracetamol and NSAIDs, but consider low dose oral morphine if pain is not controlled. Why the low dose? Because at this stage, opioid analgesics provide additional pain relief while maintaining the child's comfort. Step 4, moderate to severe pain, and it scores 8 to 9. Here, increase the dose of oral morphine and ensure it's administered regularly. Adjust the dose as needed based on the child's response and tolerance. Step 5 is to assess pain, severe pain. It scores 9 to 10. Here, it gives high dose oral morphine or give other strong opioids like fentanyl. Regular monitoring are essential to balance pain control and side effects such as sedation or constipation. What is role of play specialist? Play specialists are trained to support children undergoing medical procedures. They use age-appropriate tools such as interactive games or art to engage the child and reduce fear or distress. When preparation for procedure using dolls or photographs helps explain procedure to children in simple terms. For instance, showing a doll receiving an injection can make the process less interactive. Verbal preparations by talking calmly helps prepare the child emotionally. By distraction techniques, engaging the child with toys or activities, it diverts their attention away from the pen. By playing music and reading a favorite story provides a calming effect and helps the child focus on something enjoyable. And tools like sensory boards or lights can divert the child's attention and reduce their perspective of pen. For children with learning disabilities, pen assessment and distraction techniques are modified to match their developmental level. Tools specific to their mental age ensure they feel understood and supported. Let's come to the overview of the case. This case involves a 4-year-old boy with stage 4 neuroblastoma who has relapsed after undergoing chemotherapy, surgery, and radiotherapy. With no curative treatment left, the focus has shifted to palliative care, emphasizing symptoms management and improving the child's quality of life. The child experiences severe bone pain from a lytic lesion in the right femur, despite receiving oral morphine 5 mg multiple times in the past 24 hours. His pain is still not adequately controlled. The objective is to adjust his analgesic regime and explore additional interventions if the pain persists. Let's come to the first question. That is, which of the following regime would you prescribe for him? Now, select one answer only. Option A is continue with oral morphine 5 mg every 4 hours. That is wrong because continuing with oral morphine 5 mg every 4 hours works but requires frequent doses. This leads to ups and downs in pain control. The child needs consistent pain relief without frequent interruptions. Option B, oral morphine 5 mg every 3 hours. This is also wrong because increasing the frequency to every 3 hours slightly helps, but it still does not solve the problem of fluctuating pain. This approach also makes it harder for the caregiver and dispute the child's daily life with frequent dosing. Option C, it is also wrong because slow release morphine offers more stable pain control, but 5 mg is too low for this child. This child already needs at least 30 mg of morphine daily, so this dose wouldn't be effective. Option D is also wrong. Here, this dose is closer to what the child needs, that is 30 mg daily, but does not account for the recommended 25 to 30% dose increase for better pain control. The total daily dose would remain the same, which is not enough to relieve the child's current pain. So here best choice is answer E, that is slow release morphine 20 mg twice daily with oral morphine for breakthrough pain. Here is why the child is currently getting immediate release morphine 5 mg 4 hours, which adds up to 30 mg in a day. The problem is this: frequent dosing is not keeping the pain under control. Pain keeps coming back between doses, and that's hard for the child and caregivers to manage. So we need a more stable, long-lasting solution. That's where slow release morphine come in. It gives consistent pain relief for 12 hours. So instead of taking medication six times a day, the child only needs it twice a day. Here is how the dose is calculated. The current total daily dose is 30 mg, but when pain is not well controlled, as per pain management guideline recommend, we increase the dose by 25 to 30% to improve relief. So 25% increase of 30 mg into 1.25 is equal to 37.5 mg total, and 30% of 30 mg into 1.3 is equal to 39 mg total. To keep things simple, we round it to 40 mg per day and split it into 20 mg twice daily. So switching to the 20 mg slow release morphine twice daily provide consistent pain relief and simplifies dosing. The additional 4 to 8 mg immediate release morphine for breakthrough pain ensures sudden pain can be effectively managed. This approach balances effective pain control with minimal disruption to the child's quality of life. So here is the second question. Which of the following is the most appropriate approach to his femoral pain if the above increased dosing does not help? Select one answer only. Option A, epidural anesthesia. So option A is incorrect. Why? Because it involves injecting pain relief medicine near the spinal cord to block pain. While it can work for severe pain, it is invasive and might cause problems like difficulty walking or controlling the bladder. For a child in palliative care, such side effects can worsen than comfort and quality of life. Option B, further increase in oral morphine dose. It is also wrong because morphine can help with general pain. Increasing the dose too much may lead to side effects such as drowsiness, nausea, or trouble breathing. It may not target the specific bone pain caused by the latic lesion effectively. Option C is intralesional steroid. So option C is also wrong because steroids are rarely effective for bone pain caused by neuroblastoma. They work better in conditions where inflammation is the main issue. In this case, they would not provide the relief needed for the child's bone pain. So come to the option E, spinal block. It is also wrong because a spinal block is another invasive procedure similar to an epidural. It blocks pain signals but can also cause issues with movement and bladder control. These side effects are not ideal for a child receiving palliative care, where the goal is to keep them comfortable and maintain as much as normal activity as possible. So the best option is local radiotherapy because it effectively reduces pain from bone metastasis by targeting the affected area without systemic side effect. To wrap up, this case highlights the importance of tailoring pain management to the patient's specific needs, especially in palliative care. We saw how switching to slow-release morphine ensures stable and consistent pain control, while also using breakthrough doses to manage sudden spikes of pain. It's all about improving the quality of life for the patients and supporting the family during this difficult time. If you found this explanation helpful, make sure to like this video, share it with others who might benefit, and subscribe for more cases discussions like this. Feel free to leave your thoughts, questions, or feedbacks in the comments below. I had loved to hear from you. Thank you for watching. I will see you in the next video.